welcome all of you for this 18th online teaching class under the banner of UP chapter of AORI. So from today, we are going to start our breast cancer series. We know that this is a very big topic and we will try to cover all the things which is very important for your examination point of view. So we have the two dynamic personality with us today as a moderator as well as a speaker also. So for moderation, I would like to introduce Dr. Ankita Patel. She is the Senior Consultant Radiation Oncology, Apex Hospital, Varanasi. She is the past Secretary General of UP-RI and this is the Quality Head and DNB Coordinator of Apex Hospital. She has recently cleared asthma examination also. So Dr. Ankita, it is over to you.
Thank you, ma'am. A very good evening to all of you. At outset, I would like to congratulate UP-RI team for organizing these classes because for a very long time we were, all the students and everybody, we were thinking these type of classes should be organized. So yeah, thank you all of you. And I would like to introduce speaker for the day, Major Dr.M.Q.BAIG, sir. And we are all aware he's so dynamic. He is presently Professor Radiation Oncology in JK Cancer Institute, Kanpur. And he has many national and international research papers to his credit. And also he is a major author of books like Practical Radiotherapy and Chemotherapy Planning, published by JP Publication, and Concepts of Molecular Oncology. Sir has huge knowledge basically in molecular oncology. And the topic of the day is breast cancer, anatomy and IHC markers, study relevance. And we all understand breast is one of the most common cancer which we are dealing in day-to-day life, and IHC marker per se, it's really important and determining prognostic factor and predictive factor. And it is very important for residents to know what should be the preservative the concentration of formalin or the duration of fixation, the processing, etc. So, Baig sir, welcome to you, and over to you, sir.
So, good evening, everybody, and good evening to all UP-RI members. My topic of presentation is a breast cancer, and its relevance. So, the straight line for breast cancer, survival for metastatic breast cancer is 18.4 months. With this background, we'll navigate the further slides. Next slide, please. The metastasis response to chemotherapy and hormone therapy as well, but we practice the radiotherapy for acute response. Distant mets can occur in a breast carcinoma as long as 25 to 30 years after the diagnosis, but even the breast carcinoma metastasis occur within 5 years of diagnosis of primary site. If a tumor is 1 to 2.5 centimeter, so that the size of the breast cancer, the tumor size, having a direct impact on the metastatic potential of this tumor. That's an overview I'm giving you. The node positive patient, this period is basically developing a metastasis is 5 to 6 years, and node negative patient and node positive patient, this period reduced to 2.5 years. That means certainly the half of the period. So let us know a little bit about the anatomy of breast and the lymphatic drainage. The lymphatic drainage of the breast is a very unique in form. It's a complex, and seriously, it's having a chain of such a metastasis that you go for all sentinel lymph node biopsy or going for internal memory lymph node lymphoscintigraphy. Again, problem? Audio problem?
No, you continue, please. Okay, but voice is not very clear. If you can come close to speaker, it will be okay.
Keep it a little closer. Not because of that. So that in case of a lymph, if you go for a breast anatomy, you get first on the from a upper side to the downside. If you straight to the skin, subcutaneous tissue, the pad of fat grossly take a huge, create a huge volume for a breast contouring, connective tissue, then lobule, duct, and then ribs, and further deep down the muscles, and further to deep is bone, and that is in form of ribs. So we are focused basically on the lobule and ductule, and then its formation. And there are 2-3 cells are very unique for an immunohistochemistry point of view, that once you take out the lobule and ductule, then you, from the superior side to the inferior side, internal side, if you approach, you get an cell like luminal cells, and then myoepithelial cells, and the myoepithelial cells is further covered by the basement membrane. So this is the view of breast cancer and its relevance in case of immunohistochemistry. I'll tell you later on about the breast cancer, ductal carcinoma. This slides show you the ductal carcinoma in situ, where the tumor is limited inside the, which has got basement membrane, and hence we call it as a ductal carcinoma in situ. And an invasive ductal carcinoma, once it has penetrated, came out of the duct as in form of an invasive ductal carcinoma. So what are the luminal cells in the breast? Luminal cells in the line, the apical surface of a normal breast duct, and have a secretory property. Most breast cancer arise from the luminal cells, are heterogeneous in the expressions. And a heterogeneous means expression, they might be having a heterogeneity in this. It might be ER, PR positive, negative, or HER2 expression, overexpression, underexpression. These are the I want to express these things. So the another thing which you see in this slide, the basal cells or a myoepithelial cells covering outerly, and an inner side there is a luminal cells. You can differentiate on the basis of immunohistochemistry these cells by those. One is positive for different cytokeratin, and one is positive for different cytokeratin. So you can differentiate in that by the basis of immunohistochemistry or by the pathological eye, which is a sound pathologist can easily differentiate in that. Next slide, please. The basal cells, basal epithelial cells are located in the lower part of epithelium directly above the basement membrane. These cells are usually configured like a pyramid, the pyramid of this basal cells. A basal cell is also called is a myoepithelial cells. Both are the same things. So the pyramid, the basement membrane on the bottom and the top pointing toward the surface of the epithelium. This is the, you can see this thing, the basal cells and the myoepithelial cells. And the structure is a quite rectangular cells, but it's a pyramidal shape of basically in a histological point of view. So now I'm coming toward the breast cancer lymphatic drainage. What we see, the axillary lymphatic drainage every time is being discussed, and then we all know about the chain of a lymphatic chain axillary towards. I am taking you towards the different things. What the metastasis from the intercostal vein goes first to the aegis vein, from aegis vein to the external vertebral venous plexus. We know there is a wall, no wall between the external and internal vertebral venous plexus. Thus, metastasis of a breast goes straightway to the thoracic spine, since aegis vein lies on the bang on the thoracic spinal area. So that the thoracic metastasis is the most common site of a spinal metastasis in a breast cancer. That is the reason. So you can see here aegis vein about to enter the superior vena cava, and then the subcostal vein, aegis vein, and then the left side of the hemiaegis vein, or the right side aegis vein. This is the chain of a lymphatic drainage. So another point I want to stress upon the supraclavicular nodes, deltopectoral nodes of upper quadrant is top supraclavicular and dectopectoral, and then outer and lateral an interior group of lymph nodes, this chain of distribution of a lymphatic for a breast, and then inner and medial side goes to the internal memory, para-external nodes, and the lower and inner quadrant. This is very unique, which I'll bring you to the notice that it goes to the subdiaphragmatic plexus. From the lymphatics from the lower and inner quadrant of breast, first it comes out here and then communicate with the lymphatic plexus on the rectal sheath, and this lymphatic plexus of rectal sheath, they form the plexus and then pierce the diaphragm, and under the subdiaphragmatic plexus they communicate, and this way they communicate to the liver, so that you can categorize that the breast is hematogenous spread in the liver secondary, but also sometimes through the lymphatics, it's a breast carcinoma develop a liver secondary. So it's not a purely the hematogenous spread. It's sometimes lymphatic spread also produce the liver metastasis. So this, all the lymphatic channel use the subareolar plexus, interior node, posterior nodes, and then the supraclavicular, infraclavicular, apical, central nodes, and then again whatever I told you, that the lower and inner quadrant of breast lymphatic plexus goes to the subdiaphragmatic lymphatic plexus and abdominal cavity, and that way that goes to the tumor disseminate down the chain. So now let us come to the immunohistochemistry, the main issue, the use of immunohistochemistry. I'm telling you, and I have written a book on this. In coming 10 years, all the chemotherapy we cannot prescribe blindly, and we have to have a solid background of immunohistochemistry. And this is popping up very fast. And like in the head and neck cancer, like in cervical cancer and breast cancer, we get a pharmaceutical companies that the schedule of drugs, this rationale is this, we pump the chemotherapy, but it will not be done. And the breast is the best example that we people, we all are given a chemotherapy, CMF regime, CAF regime, CEF regime of a triple negative breast cancer without knowing the immunohistochemistry. Was it right? Certainly not. But we had limitations also, because we don't have that period of time, the immunohistochemistry as a fashion of investigation. And now it is a need. So I'm telling you that the chemotherapy protocols will be entirely depend upon this. And this is the cutting edge for a radiation oncologist and as well as the medical oncologist. Why we have a bi-edged weapon? We radiation oncologists have a bi-edged weapon because he having in his arm two things. One is the medical oncology, second is the radiation oncology. So why we should leave this thing? We already captured the radiation oncology comprehensively. We'll capture in the next step the medical oncology as well by knowing these immunohistochemistry and the chain of chemotherapy giving. So let us come back to this immunohistochemistry used to characterize the intracellular protein or a various cell surface in all the breast tissues. The individual marker or more often panel of various markers, example protein marker as well as other surface markers, characterize the various detail about the tumor characters. So role of immunohistochemistry in breast cancer, particularly breast cancer, it decides the subtypes of breast. There is external, what are the HER2 new positive? They categorize on the basis of that. I'll come to further slides. First, it categorizes subtypes. So in order to design the chemotherapy protocol for that particular subtype, metastatic from primary tumor to the metastasis from the primary tumor. So a metastatic and a primary tumor is decided by immunohistochemistry, provide additional information which is important for prognosis, predicting response to the therapy, evaluating residual tumor, post-tumor. These are the role of immunohistochemistry, which is we need to know. So what are the biological characteristics of tumor? are used to make the prognosis and select the appropriate systemic chemotherapy for patients with a breast cancer. We all know the breast is not a local disease, it's a systemic disease. The systemic disease means we already knew that the trial being conducted, that so many patients is being investigated in early breast cancer. They found to have a metastatic in their bone marrow and the metastatic seeding of the cells. So that the chemotherapy is a very cornerstone for the breast cancer management till now. The advent of, and then also we know that no patient dies because of a scar recurrence. In our experience, the most of the 10% patient of a breast cancer dies because of systemic metastasis. So we have to take care of this thing also. And the chemo surgery and the radiotherapy provide the local control. Sometimes some studies says that the local control also take care of the distant metastasis as well. So advent of molecular technology and molecular oncology has incorporated the new biomarkers along with the immunohistochemistry and a serum biomarkers. Like in a breast cancer, I've told you the myoepithelial or basal cells as a marker used. The expression on these cells, the receptor and present on the antigens present on these cells, myoepithelial and basal cells, are useful in distinguishing the benign lesion from a malignant lesion. Very basic of a breast cancer can be decided by the breast immunohistochemistry, whether it is a malignant or a benign lesion. The most common immunohistochemical breast cancer prognostic and therapeutic markers, which is usually practiced, are what? The estrogen receptor, human epidermal growth factor 2, Ki67. So what is Ki? We need to know what is Ki. Ki means that Kiel. Kiel is the city in the Germany where this surface receptor was diagnosed, and then a city named Kiel from a Germany country is this marker is being endorsed. The progesterone receptor, then BCL2. What is BCL2? We should know. What is BCL2? It's a B cell lymphoma. Actually, first diagnosed there. Because of that, it's an apoptotic gene which is present there as a marker of apoptosis. But there is also a P53. But the role of P53 in the latest study is being debatable, that which we should do or not. But the BCL2 is being registered, that we should all do. Marker for angiogenesis are also very important. That is V vascular endothelial growth factors. So the diagnostic markers, immunohistochemistry can be used to identify the histological types or a molecular subtypes or phenotypes of differential diagnosis of various types of benign and malignant lesion. First, they are also differentiating between the carcinoma in situ and invasive carcinoma. That's immunohistochemistry. Diagnosis and differentiation of microinvasion and its limiting imitating lesion and confirming the breast as the primary site is also being by the immunohistochemistry. So whatever the plethora of information we are getting by the, by this immunohistochemistry study only. So the normal glandular breast tissue is composed of two cell types, which express different subsets of protein. One is luminal, I told you. Second is the basal. For immunohistochemistry eyes, we are not interested to know about the pad of fat, connective tissue. We are specifically hitting the cell. That cell is, one is luminal, second is basal or myoepithelial. So the luminal cells express cytokeratin, epithelial membrane antigen, estrogen receptor, and progesterone receptors. And what does the basal and myoepithelial cell depicts? Give you information. What information you reveal from the myoepithelial and basal cells of cytokeratin? One is the smooth muscle actin, calponin, S100 and P63. S100 protein you must have heard also investigating for immunohistochemistry for multiple myeloma. For melanoma. So P63 is again not a P53. It's basically P63 is a homologue of a P53. So what we have up now, what you get here, you can see in this chart that luminal A, luminal B is further classified. What is luminal A, what is luminal B, and will come in the next subsequent slides. The myoepithelial markers like SMA, calponin, P63, the myoepithelial markers are useful in helping you distinguish the invasive from benign to malignant. Invasive carcinoma precisely lack of myoepithelial layer that is normally surrounding the benign or a normal breast gland. So that is the baseline information which you can collect. The invasive carcinoma and the carcinoma in situ of benign lesion, you have a connecting link that the myoepithelials, if it is absent, lack, that means it is an invasive carcinoma because it has been destroyed. So P63 is a homologue of P53. What is P? I mean, what is P? I just wanted to know what was P3 is basically protein 53. Protein 53 and protein 63. It has been shown to be expressed exclusively in myoepithelials of normal breast. It is very useful in differentiating diagnosis. That's already I've told you, benign versus malignant lesion, papillary lesion. Using P63, it's a nuclear localization. It's nuclear localization. Basically, it's obviously it's a gene. It's localized in the nucleus. An absence of staining of smooth muscles, such as myofibroblast or a blood vessels, the smooth vessels blood in the artery, they actually do not stain for using P53. So it's a very, very specific P63. It provides 100% specificity for investigation of immunohistochemistry to differentiate between the benign and the malignant as. So now come to the lobular carcinoma or a ductal carcinoma. The E-cathedrine CK8, cytokeratin 8 and E-cathedrine, determining whether in situ lesion is a lobular carcinoma or a ductal carcinoma, is another situation in which immunohistochemistry proves its vital role. The immunohistochemistry E-cathedrine is currently used to differentiate between the two, whether it is lobular or a ductal. So the majority of a ductal carcinoma express cathedrine, where the most lobular carcinoma lack expression of E-cathedrine. That is another useful information we get. Next slide, please. Identification of subtype of breast cancer, which I just wanted to earlier I stressed upon. The analysis of both adjuvant and neoadjuvant trial has shown that not all chemotherapies have an equal effect on a breast cancer patient. Therefore, further chemotherapy is required. There are significant differences. So there is a breast cancer conference happening in Switzerland, St. Gallen City, in the March 2011. That was the 12th International Breast Cancer Conference. Receptor, overexpression and amplification of human epidermal growth factor receptor 2 and its treatment. So what was this? Actually, they have explained, actually, the entire things was based on the immunohistochemistry findings. So they have what they have categorized this. One is luminal A. Luminal, what is luminal A? Means ER positive cancer called A. What is luminal B? So luminal B were PR positive, but they also considered HER2 positive or negative. They are beta, luminal B. And third was the HER2 new overexpression and a basal cell line. So they actually indeed there was a 3 category. broadly speaking, they have on the basis of expression of the receptors, that is steroid receptors as well as the protein receptors. So now they have also suggested therapy alone is sufficient. For luminal B, that is HER2 negative, endocrine therapy plus minus cytotoxic therapy is recommended. Then further they have for luminal B, I told you that may be either HER2 negative or HER2 positive. So the for luminal B, HER2 positive variety, cytotoxic chemotherapy, anti-HER2 monoclonal antibodies plus endocrine therapy, all is required. On the fourth, cytotoxic chemotherapy plus anti-HER2 for HER2 positive, non-luminal variety, and a cytotoxic chemotherapy for triple negative. So they have categorized in this way to hit the management of breast cancer part as a hormone treatment and the as well as the chemotherapy treatment. So there are markers also which depicts the metastatic potential of a breast carcinoma, which says clearly that if the markers are overexpressed, that the chances of metastatic potential is very high. You have to keep the patient on the vigil, and then the patient has to be advised the prognosis about the same. So in this situation, a positive reaction for cytokeratin and a lack of reactivity of lymph node markers suggests a diagnosis of metastasis. In case of a large metastasis in axillary lymph node, ISC can demonstrate by a positive reaction for epithelial markers. Carcinomatous nature of the cells difficult to appreciate as epithelial. I mean, if you see the lymph node, the large lymph node, ISC demonstrate a positive reaction. That means the chances is grim that the metastatic potential is very high. In particular, in case of axillary metastasis of infiltrating lobular carcinoma, relatively uniform appearance of tumor and low mitotic activity. So in case axillary metastasis you got, and you got from axillary metastasis, you take a tissue for a immunohistochemistry. So, and you get a diagnosis of infiltrating lobular carcinoma. So what you will get it here, the uniform appearance of a tumor cells and a low mitotic activity will be there. But of small metastasis in infiltrating lobular carcinoma, false negative results are more common than infiltrating ductal carcinoma. That is also information. So markers to the diagnostic panel we usually cover is ER, PR, androgen receptor, HER2 new, mammoglobin. Mammoglobin is unique. I'll come back to the mammoglobin, and cytokeratin from 7 and 20. So in this context, androgen receptor and HER2 negative are given additional value in greater number of ER negative high-grade ductal carcinoma. Lately, mammoglobin has been described as a breast cancer specific gene. So let us know about what is mammoglobin. Mammoglobin is being identified as classified as a mammoglobin A and a B, identified in a breast cells and overexpressed in the breast cancer. Mammoglobin A is more specific for breast and gynecological cancers, but myoglobin B may be found in a number of other tumors, including the breast cancer, especially the gastrointestinal malignancies. So how we go for this testing of this? So as of now, the recommendation is the most common histochemical breast cancer prognostic and therapeutic markers which we are including is ER, PR, HER2, Ki67, and P53, BCL2. But P53, I told you, does not have any clinical significance over the BCL2. They have included, they have skipped the P53. So the recommended is ER, PR, HER2, Ki67, PR, and then BCL2, and that is anti-apoptotic genes. And addition to that of angiogenesis marker, that is vasculoendothelial growth factors. So the hormone receptors that they have actually classified the receptors, how we consider these receptors. Like suppose I'm putting you a question that we have already discussed with a few of my juniors and their colleagues also. Why the ER/PR negative patients respond still to the estrogen treatment despite they are ER/PR negative? So why they respond? 15% response is there. Reason is simple. The ER/PR study is a quantitative analysis. Is quantitative analysis. If 10 femmole, estrogen positive, 5 femmole, estrogen, progesterone positive. If suppose it is 9 femmole, you say it is negative, but still they have as receptors. So that is the quantity basically, so that it still responds. That is the idea before expressing myself. To bring your people under this thing. The first scoring system counted the percentage of positive cells and ignored staining. When we determine the proportion of positive stained cells, at least 1% is considered as a hormonally treatable state. It means if a 1% of the cell is expressing the receptor status positive status, then you must treat the patient with a hormone treatment. According to the International Breast Cancer Study Group scheme, which is the basis of most recent St. Gallen treatment guidelines, the breast cancer is divided into 3 categories. Basically, response, uncertain, and non-responsive. Responsive, even if 10% is cells are there. Response uncertain if 1 to 9% are there. Cells, those who are taking a positive stain for estrogen or a progesterone. And if a non-responsive, even 0%, in other words, the 1% of positive cell indicate the option for hormone. That is the idea. But these guidelines, please note down, these guidelines widely followed in many countries, including Europe and United States, but still seem to be insufficient. So what was the another things which popped up to overcome these limitations of these guidelines? So the guidelines limitation was further comprehensively taken care by the National Surgical Adjuvant Breast and Bowel Project Protocol B24 findings. The finding were in the patient with ductal carcinoma in situ with a partial mastectomy and then irradiation who received placebo or a tamoxifen for 5 years showed a conclusive reduction in both ipsilateral and contralateral breast adjuvant tamoxifen group. So what he described that HER2 new was one of the first oncogene studies in sample invasive breast cancer, identified 10 to 20% of breast cancer patient in Europe, and a 20 to 30% probably is that 20 to 40% probability is basically in an Indian population is being recognized. It is a marker of sensitivity to Herceptin, that is trastuzumab, and resistance to the tamoxifen. Means if it is HER2 positive, that means it will respond to the trastuzumab, but it will not respond to the tamoxifen. Though these patients still have some response to anastrozole and aromatase inhibitors indeed. Although the HER2 new can be detected using many methods, only 2 are currently approved. So that for immunohistochemistry, you have 2 things, either immunohistochemistry proper or FISH technique, fluorescent in situ hybridization. So both are molecular marker test, the genetic level test. But what is the difference between 2? One is the ISC evaluates the overexpression of receptor protein at the surface of the cells. That is very important. It's receptor protein on the surface of the cells. So it is less impactful. But the more impactful is the FISH, which we evaluate the status of HER2 gene at the nucleus level. That is more, this is a more authentic. Basically, if you classify this, it's everybody can say that the FISH is more impactful test. So the majority of HER2 positive cancer protein overexpression is due to result of genetic amplification and thus both methods should be highly correlated. The immunohistochemistry reaction for GR2 is scored by Herceptin test, that a 0 to 1 score is considered to be negative, 2 plus is weak positive, and 3 plus is positive. And result intense membrane staining more than 30% of a tumor cells. I mean, no, here it is again expressing the now I'm audible now. So what I have wanted to tell you about the scoring system of GR2 positive Herceptin test, that the 0 to 1 is considered to be negative, 2 plus is weak positive, 3 plus is positive. A positive HER2 test is being described by the National Adjuvant Breast and Bowel Project that a 30% of the tumor cells, if it is positive, of entire tissue examined, it is considered to be positive test. The weak positive equivalent to 2 plus case should be treated for a gene amplification by now. Now you see the superiority of immunohistochemistry, strengthened by the FISH technology, that a weak positive or equal of 2 plus cases or weak positive cases should be retested for a gene amplification by FISH, whether it is not or not, because the treatment policy will change. So now I'm coming on the next slide, please. The markers of apoptosis and a cell proliferation, which is also important because it is the basically recurrence of a primary site, it's true recurrence, or sometimes metastasis is entirely dependent upon these markers. So the Ki-67, I've already told you about this, derived from the Kiel city of Germany, discovered in medical university, discovered in 1983. This Ki-97 is basically polymerase 1 dependent ribosomal RNA synthesis, predictive and prognostic marker in a breast cancer has been extensively studied. So Ki-7, basically Ki-67 level is above 10 to 14%. Breast cancer patients are defined as the high risk. So if you find out in the immunohistochemistry the Ki-67 is above 10 to 14%, then it is metastatic potential of breast cancer. This breast cancer is very high. So according to the St. Gallen Consensus 2009, the Ki-67 index is useful for selecting the patient for hormone receptor. The positive breast cancer for addiction of chemotherapy with endocrine. So the breast tumors are classified low, intermediate, and high proliferating according to Ki-67 labeling index. So what was the index? That 15% for low, that is low risk, or 16 to 30%, that is intermediate risk, or 30% high risk cases. So the Ki expression was associated with the additional independent prognostic parameter for disease-free survival, overall survival of breast cancer patient. So you get so many information by these tests. It is known that the patient with triple negative breast cancer survival responds highest rate to a neoadjuvant chemotherapy. So those with a high Ki-67 have more aggressive clinical features. Both BCL2 and P53, which were involved in apoptosis and a cell proliferation, play important role in determining the tumor growth and may help define the high-risk patient more accurately. But I told you previously also the P53 role is little not very validated till now, but the BCL role is being validated so far as the breast cancer is concerned. So if we compare the patient with ER positive BCL2 negative disease to those with ER negative and BCL2 positive disease, the former have been found to have a worse prognosis because BCL2 is an anti-apoptotic gene, and if it is not there, so that's a prognosis. The prognostic value of BCL2 is present across the molecular subtypes and is independent of parameters such as stage of a disease, grade of a tumor, and tumor size. So the BCL2 almost independent of these things, the tumor size and dimensions. BCL2 can be used to prevent the patient from undergoing the unnecessary cytotoxic therapy and provide additional prognostic information. And then P53 status in a breast cancer with regard to that's we are skipping this value of 50 to 2 week to be recommended as a routine marker in clinical practice. So now the another parts of very vital for a breast cancer, the angiogenesis. Growth and metastatic potentials depend on the tumor angiogenesis, and this complex process involves a delicate balance between angiogenic and anti-angiogenic factors. If angiogenic factors overcoming the anti-angiogenic factors, then certainly the tumor has to grow. The numerous studies have investigated the relationship between the tumor angiogenesis, prognosis, and response to the anti-angiogenic drugs. The tumors secrete VGEF. In this picture, you see the vasculoendothelial growth factors, and there are multiple igniting factors which bring the tumor to secrete vasculoendothelial growth factor, and these vasculoendothelial growth factor, they keep a formation of a new blood vessels, new vascularization, and then the tumor size increases and the recurrence happens, and this is the way it happens. So analysis of these factors in tumor or serum of a breast cancer patient by immunohistochemistry or multiplex protein assay can be improved diagnosis and prognosis of disease. There is a large list regarding the angiogenic markers. What are the markers? Basically, angiogenin, angiogenin 2, fibroblast growth factor, in platelet-derived growth factor, vasculoendothelial growth factor. But as of now, we are doing vasculoendothelial growth factor study on the tissue, and that to be the tissue from primary tumor site, not from a metastatic site. That is the limitation we have as of now. So the commonly used method to determine the angiogenesis is counting the intratumoral blood vessel density, basically. How many numbers are there? Stained with a factor 8 related antigen or anti-CD31 and CD34 using light microscopy. Newly formed stained microvessel is useful tool in early detection of metastatic potential of the breast cancer, and also help in selecting the anti-angiogenesis drugs might be beneficial. So without testing this vasculoendothelial growth factor, we can prescribe the patient bevacizumab or like a anti-angiogenesis drug. So the reactivity of CD34 assessed by the immuno. So that's anti-angiogenic drugs have been approved recently for therapy of advanced cancer, including breast cancer, colorectal cancer. These drugs alone or a combination of chemotherapy able to improve the overall survival and progression-free survival in cancer patients. Most of the biological and clinical activity of anti-angiogenic drugs currently approved for the cancer therapy against the vasculoendothelial growth factor related pathways. So, I just want to share information. We have a very traditional capsule available with us all over the market, and it's basically anti-angiogenic, antithrombostatin. And that capsule name is doxycycline. It is again anti-angiogenic drug. So, and that is the reason why we prescribe in a COVID era the doxycycline. That is the philosophy behind the doxycycline, but they shipped from the Europe straight away to the India. Is just hack of it, just casually not written doxycycline. There's a philosophy behind it. So let us come to this thing. So the vasculoendothelial growth factor system is a part of platelet-derived growth factor gene family, interact with a specific receptor, vasculoendothelial factor 1, 2, A, B. So it's going in the depth is basically actually this lecture is I think it is designed for a pathologist basically, but I have been trapped by my secretary here. Unfortunately, the lack of validated biomarkers allowed to the selection of patients who are most likely to benefit from targeted drugs, that is bevacizumab, sunitinib, sorafenib, pazopanib, limit the rational use of these drugs and ability to determine the optimal dose and scheduling of these drugs. So what is the conclusion of my talk? The immunohistochemistry has become an integral part of a pathological laboratory and an oncology treatment. It is more mature technology accessible to majority of pathological laboratories. Immunohistochemistry can be used for a diagnostic issues, estimating the prognosis, and as well as predicting the response to the therapy. The best approach in the use of immunohistochemistry chemistry markers is to combine them with the examination of the standard panel of markers. So further it strengthens the one examination report by the other examination reports, so that you have a more impactful knowledge about the tumor. Reactivity of steroid receptors were observed to be decreasing with increasing grade. That is also information we got it. A grade 3 tumor were more receptor status negative as compared to grade 1 and grade 2 tumor. This shows the same inverse relation between the receptor status and increasing tumor grade. A grade 3 tumor were more receptor status negative as compared to grade 3 tumor. So thank you all. Long live UP-Aroi. Thank you very much, my president, Professor Salim sir, and my secretary, Professor Surbi Gupta, for inviting me for this lecture. I know this lecture was not very good because quite boring also, but whatever I could, I delivered. Thank you very much. And any question you can raise.
Yeah, thank you, Dr. Baig, for such a elaborative presentation. So we have few questions in chat box, and everybody is open for the questions and discussion. So the first question is GCD-FP, that is gross cystic disease fluid protein 15, are 100% diagnostic for mammary origin?
So it is not 100% surety for this thing. What if what question was, probably I could guess this question was, is GCD-FP15 are 100% diagnostic for mammary origin? Certainly not. Certainly not. Answer is not. It's give you idea about this thing, but it is not 100% diagnostic for mammary origin. Okay, fine. The first answer is being given. What is the second question?
Okay, sir, the question is, what is the Ki-67 threshold? Like if we when we divide the subtypes in luminal A, B, there is it's Ki-67 low. So what is that threshold?
Threshold level is, I mean, this such though no information is being gathered from by me. What is the actually amount? Basically, they have given in a percentage that Ki level in a tumor tissue, on a breast tumor tissue, if it is 10 to 14%, above 10 to 14%, the breast cancer patient is a higher risk. But for this Ki value of this, like say like ERPR, we got a value of a 10 and a 5 mole or something like. You can get into the depth of the further depth, and you can get an information regarding this.
Can I answer, Dr. Ankita? I think
yes.
it's 15%. Full literature
yes,
says this is 20%, but most of the literature says it is 15%.
Yes, madam. Yes. Okay.
So
Ki-67 low is less than 15%, and high, which makes the disease luminal B, it will be above 15%. So, is there any change in treatment decision if there is receptor discordance between primary tumor and metastatic axillary lymph node?
Okay. So the question is there any change in the decision or receptor discordance between the primary tumor and metastatic axillary lymph node? First of all, it is being preferably recommended that if you take a biopsy for a immunohistochemistry and of receptor status, please go for a primary tumor site, not from a metastatic site. That is the one thing that you go for a primary. But like in a vascular endothelial growth factor, it is recommended by the New England Journal of Medicine research paper that you have to take the tumor from the primary tumor site for a biopsy or immunohistochemistry. Now the question is still is there any treatment decision if there is any receptor discordance? certainly receptor discordance. How it is possible? Because we are focused basically from the primary tumor site. We will go for another histochemistry, and certainly if we get an information from a primary tumor site, we will certainly not advise to go for a metastatic axillary lymph node. And if it is, we are getting only information from metastatic axillary lymph node, time you are not even allowed that you do a biopsy from a primary axillary lymph node as well as primary tumor site. It is basically a research part, but for treatment part, either you take a metastatic axillary lymph node biopsy or you take a primary tumor and you get one information. There is no discordance happens when there is a disparity. There is no disparity that where from tumor taken from biopsy. Next question, please.
Okay.
What are the probability of molecular subtypes after chemotherapy? That is the question probably.
Yeah, before that, should IFC be repeated in new metastasis?
Molecular subtype change after chemotherapy. Okay. After molecular subtype change after chemotherapy, there is, the chemotherapy which we designed after the immunohistochemistry molecular subtypes, it's not a chemotherapy which is given standard induction or adjuvant 6-cycle chemotherapy. It is basically a long duration maintenance and induction chemotherapy which is being pumped to the systemic breast cancer. So there is no change of a chemotherapy. Why to change the chemotherapy? Subtypes.
Actually, Dr. Baig,
first I have categorized the subtype of chemotherapy and we go for along with this chemotherapy. Why will change? Suppose ER negative or a subtypes different like the ER positive, PR positive, HER2 negative. So now the chemotherapy we got in hand, designed, and we will go along with this chemotherapy. If a triple negative patient, then it is again a subtype. Now we will go for a carbo chemotherapy for a long term because of this thing, the chances of systemic metastasis is very high. So we have already decided classification of my tumor, breast cancer, that what kind of chemotherapy we'll go for.
Dr. Baig, can I say something?
Please.
Actually, she just want to ask if there is again a discordance after giving the neoadjuvant chemotherapy. I just want to answer this question that we have done this research in our department and we published a paper also that after giving the 4 cycles of neoadjuvant chemotherapy, there was seen discordance in the ER and PR receptor. And this was more in case of the PR receptor, which became negative to positive. Though the patient taken was only 30, but we have seen that this discordance was more in PR as compared to ER. But definitely there was discordance. Dr. Ankita, you want to say something?
Yes. So yes, you are true, ma'am. So that definitely changes our plan. If we are planning upfront surgery, suppose we have taken FNAC or biopsy and it's confirmed it's malignancy, but we are awaiting IHC for ERPR status. And if upfront surgery is planned, we can go ahead. But if we have to plan NSAT, we have to wait for ERPR status because once we give chemotherapy, there may be changes. So that is one important point. And secondly, if there is any new metastatic lesion after some disease-free interval, or there is some new lesion, or there is progression during the neoadjuvant or adjuvant chemotherapy, definitely repeat biopsy and repeat IHC should be done.
Agree.
So sir, the question is by me only. What should be the once the biopsy is taken? What should be the preservation medium duration acceptable before processing? Because that is very important. We send the sample and it comes inconclusive or lysis is there. So what this should be the take-home message for the residents after the biopsy. What should be the ideal the preservative media with what percentage of formalin and also how much? What is the acceptable duration? So
again, network issue, Dr. Ankita, you can proceed.
So it should be 10% formalin and the tissue should be processed within 6 to 8 hours, not more than 48 hours. It should not go beyond 48 hours. Otherwise, there is tissue destruction. and it is very commonly happening.
Yeah, usually we get the autolyzed specimen after this.
Yes. Yeah. Also, one more point I want to take up. For IHC HER2 immunochemistry, the guideline has been changed. According to 2018 ESCO CAP, initially it was 30% membrane staining, but now it's more than 10%. So they have just reduced the threshold. To the resident, I would request whenever you get any histopathology, any IHC histopathology, please go it thoroughly, because after histopathology report, they very beautifully with latest guidelines and very beautiful tables they are giving with clear description of medium, the thresholds, everything they are writing. So, and also what are various responses depending on the percentage of ER/PR. So, a request to all the residents to go through histopathology thoroughly from page 1 to page 10, not just ER positive, PR positive. That is very important. That is how we'll learn it.
There's one question. Any comment on the androgen receptor as the potential target? I just want to say that, yeah, this is pipeline, but until date, till date, it has not been recommended. We have not, we cannot decide our treatment only on this androgen receptor basis. I think in near future, we will be able to decide our decision, our treatment decision on this androgen receptor. Dr. Ankita?
Yes, ma'am. Yes, ma'am. We have huge basket of anti-androgen target medications as we are using in CA prostate, but in CA breast, it is yes, potential new therapeutic target, but not yet established. But many consultants, they are now getting AR receptor testing done, but yes, they are not being implemented in treatment.
Yeah. Next question is already score. Yeah, it is better than percentage. Just using the percentage, I think already is more acceptable for this ERPR receptors. Any view? Dr. Baig, can you hear?
I can hear.
Dr. Ankita, you can comment on this. What is your view?
Yes, it is definitely better.
Can I say something?
Yeah, definitely.
Okay, I'm audible?
Yeah, you're audible.
Actually, okay, fine. What was the question?
Is reporting ER/PR through already score is better than just using percentage of cells stained?
Okay, that ER/PR status is basically positivity. The percentage of positive cells in the in ratio of the tumor's volume, which is being set for the immunohistochemistry or escapes. So that depends upon the the pathologist will certainly report you as that the ER/PR contains positive. Into that we go for a treatment. Basically, that is intermediate, low risk, intermediate, and high risk. So according to that, being discussed that only merely 1% of the cells being volume of the cells is positive. That's you required to start the hormone treatment if it is positive. Hopefully, I'm clear now.
Yes, sir. I would like to come.
Anybody can do something. Some important information is missing.
The LRAT score, it combines the percentage of positive cell definitely, and also the intensity of reaction. So definitely it will be better and more informative.
Yeah.
I think there's no more question there.
10 past 9, I think we should wind up now.
Yeah.
We need to catch a train to Gorakhpur.
So we can conclude now, Dr. Ankita?
Yes, madam. Yes.
So thank you so much, Dr. Baig, for giving such valuable information. Though there was a technical issue and network problem, but in spite of that, you completed your talk very well. Thank you so much. And thank you so much, Dr. Ankita, making this talk so interactive and giving answers to questions of residents. Thank you all the participants for joining us. Thank you all. Good night.
Thank you. Thank you. Good night.
Thank you, ma'am.